Hi there, and welcome to this week's Facebook Live. I'm Dr. Iris Wang, and I'm delighted to be here. I thought I should introduce myself first. I'm one of the fertility specialists at IVF Australia. I'm a senior university graduate. I did general training at RPA and St. George Hospital. I then went to Canada to do subspecialty training in reproductive endocrinology and infertility. After qualifying, I came back to Sydney to start private practice. So I've been in private practice for 25 years now. Over the years, I did a lot of fertility, but I also did a lot of general obstetrics and gynecology. And I remain one of the few fertility specialists who still do obstetrics. I still deliver babies. But for the last 3 or 5 years, I've kind of concentrated more on the fertility work, coming back to my first love, if you like. And I consult at Chatswood in my own rooms. I also consult at the Burwood IVF Australia office. So what we're doing here is talking about eggs, and more specifically, the running out of eggs. Now, I'd love you to post any of your questions. What I would intend to do is just do a short introductory chat about running out of eggs and low AMH, and then I shall endeavor to answer as many of your questions as I possibly can. Okay, so eggs. Now, how many times have you heard this? All you need is one good egg, one good sperm. I certainly heard that a lot from my senior consultants when I was in training. And that sounds really simple. And yet the reality is that good egg can be very hard to find sometimes. And over the years, I've seen a lot of progress in fertility treatment. But how do we change egg quality, and particularly in the presence of ovarian aging? That unfortunately remains, well, kind of the holy grail of fertility treatment. Now, there's no doubt that all of us women would run out of eggs. It doesn't matter how healthy or how fit we are, and we run out of eggs fairly early in our lives, as opposed to men who continue to produce sperm throughout their lives. Of course, their production declines with age. And so what I like to do is show you a graph, because, you know, a picture paints 1,000 words. So I'll show you this graph first. So you've got egg number on the vertical axis, age on the horizontal axis. And that shows the finality of egg numbers we have. And the interesting thing is we have our peak number of eggs when we're fetuses in our bodies, in our mother's womb. And by the time we're born, you can see we're down to half of all our eggs. And then by the time, you know, here we are, we reach puberty, started menstruating and ovulating, we're down to less than a quarter of all our eggs. And then, of course, we'll keep running them down to menopause, and then everything's finished. So the reality is we end up wasting more eggs than we ovulate them. Now, of course, we've known about this forever, but it is only the last 15 years or so that we've been able to measure egg reserve using the AMH assay. Now, some people call it egg count test. I've heard a lot of people call it that. But basically, AMH stands for anti-Mullerian hormone. And it is a hormone that's produced by all the little eggs sitting around on our ovary. And they're kind of ready to do their job, if you like. So a measurement of AMH is a perfect reflection of our egg reserve. So here, of course, I have to show you the AMH reference range. And here we have the AMH level on the vertical axis, and then on the horizontal axis, we've got the age of the woman. The most obvious thing is this green bar, this big green bar here. That is the population average of AMH level. So we all fall, most of us fall in this range, but obviously our level goes down gradually as we run out of eggs. So when we say egg numbers are low or AMH level is low, there's got to be a cutoff. Now, every lab is different and what's the cutoff you use. So it's kind of an arbitrary number. But here in IVF Australia, we've used 8 as a cutoff point. But probably more important is the comparison of your level against your peers, your age-matched peers. So I'll give you an example. So here, let's say I'm 32, okay, 32. And my level is 12, so coming around 12, coming around here. So my point is somewhere here. So I'm still normal, but the thing is, compared with my age-matched peers, I'm way below the 25th centile. And another example is, let's say my number, or let's pick, say 20, or maybe 20 is about here, but I'm 43. See, well, I'm way above my age-matched peers. And where most of my peers are somewhere here, between 15 and even down to 2, for example. So what this tells us is that we're all different. And some of us have bigger egg stores than others. But I've already said, good egg, good quality is the most important. And the problem is, unfortunately, we don't have a test for that. But we do know a few things, some general ideas about egg quality, and some of the important things I'd like to share them with you. So we know that we tend to use our better eggs when we're younger, poorer quality eggs when we're older. So age becomes more important a factor than just the AMH level on its own. And of course, everyone's different, but generally speaking, AMH level, or I should say, no, egg quality starts declining from 35 onwards. And from 37, 38 onwards, that decline becomes more significant. But 40 down, it's a really sharp decline in egg quality. So the important thing is age is far more important influencing egg quality and fertility potential than AMH level on its own. Now, you know, I gave you some examples of the AMH level versus age earlier. So a young woman may have a low AMH level, but she may still have good eggs. In fact, she more than likely, she's still got good quality eggs. It's just that she has less of them. So getting a low AMH level is not the end of the world, but it's a good prompter for people who really want to have children to start reassessing their life's priority and maybe start thinking about having children earlier, if at all possible. And then the other example I gave you is a woman who's older, but with really good egg numbers. It doesn't mean her egg quality is actually good. She may potentially have lots of eggs there, but they're all poor quality eggs. However, I have to say, if you're 40 or 43 or 45 and want to get pregnant, you are better off having a higher AMH than a lower one, because it means you've got more eggs and there's more chance out of those eggs we can find that one good egg. And I think the final thing I wanted to say is that, unfortunately, egg quality is preset We can't change that. And I've already sort of alluded to this. There's a huge amount of research into this area. Now, I might come back to you 2 or 3 years' time and I'll tell you something totally different. But as of now, the present, we don't have anything we can give you to improve egg quality. Of course, there's a lot of claims and remedies out there when you look up the internet. None of these things have been proven in properly conducted clinical trials. So these are kind of the main things I wanted to tell you first. And I've got one question here already, which goes to what I really should talk to you about. There's someone who asked the question, so what can I do when the eggs are running out? And I assume that means AMH is low. I think it's a common sense kind of approach. And obviously, you know, I assume having children is very important to you. And unfortunately, the answer involves a lot of intervention. By that, I mean IVF. So if you can it's feasible, then try and have children now, soon. And you may not need any fertility treatment because you may still have good quality eggs, so you can get pregnant quickly. But obviously, if you're trying and not succeeding, and you know your AMH level is low, I think it's good to go to your doctor and seek attention early. So rather than waiting 12 months to go to the doctor, you probably should just wait till 6 months. And if you're, you know, if you're a bit older, you probably should just try 3 or 4 months before you go to see the doctor. At least get some fertility tests done to make sure there's nothing confounding you, no sperm factors, no tubal factors, nothing else making things worse for you. And then you two can sit down and make a plan as to how long do you keep trying for before we should consider intervention. And by intervention, I really mean IVF, because I think if your egg quality is low, you really want to use the most effective way of getting pregnant rather than using some of the more simple methods which have lower fertility chances. And also, the other thing is once you do succeed having a child, I think you should try and shorten the gap between children as much as you can. Again, all this is like sort of ideal circumstances. You need to take your circumstances into consideration. You know, is it practical for you to have children now? And in terms of the gap, can I possibly only have a gap of 6 months when the other baby's so young, and all those kind of things. Now, of course, not everyone is in a position to say, oh, I can just drop everything, you know, forget about my study, forget about my career, and I'm going to try and have kids now. So the other consideration you can undertake is potentially either freeze embryos or freeze eggs. And both of these will involve IVF treatment, unfortunately. Now, I have a question from Nikki. Nikki says, I have a low AMH. Am I still able to donate eggs? Well, Nikki, thank you for your question. That's a lovely idea. It's so good to have people who have that altruistic instinct and wanted to help others. But I think when you have a low AMH level, the most important thing is you need to be sure your needs are met first. So have you had children? Is your family complete? And if you want to donate eggs, we absolutely welcome you to do so. Because like I said, a low AMH level doesn't necessarily mean you do not have good egg quality. So yes, of course you can. And then I have questions from Kate. Do you believe in immune system and if alpha matching tests? All right, Kate, straight into the controversial area. That is controversial. Now, the reality is For fertility to work, everything got to line up. The egg, the sperm, the stimulation cycle, the embryo, the uterus. So there are so many factors involved. It is possible immune factors are involved. And if you've been trying for some time, I think it is important to look at the major issues first, but then come back to the immune factor as a secondary consideration. I hope that kind of answers your question. So what are some of the, Kelly's asking, what are some of the symptoms of early menopause for someone that's in their late 20s or 30s? Okay, and Kelly, menopausal symptoms. So when people reach menopause, the reality is majority of people reach menopause close to 50. The average age is 51.3. And the interesting thing is 60 to 70% of people reach menopause without any symptom whatsoever. The period comes, regular, and then everything just stops. So the amount of people who have symptoms are actually the minority, but we, of course, will hear about them a lot because they are, pretty horrible for them. So there will be things like hot flushes, difficulty concentrating, trouble sleeping, and mood symptoms, so getting moody more easily. There's a variety of these kind of symptoms. If you at all think that's happening with you, the best thing to do is go to your doctor and get some tests done. And a lot of times we can't actually predict, you see, because with AMH, the interesting thing about AMH is we can't say to a person who's got low AMH what their fertility potential really is because we don't know about egg quality. And we can't really use AMH to predict when they're going to be menopausal either. So there's still going to be a lot of questions around that. But if you have those kind of concerns, I think, yes, definitely go think about those symptoms and maybe go and check with your doctors. And Kelly also asked, what's the process of getting an AMH test? Do I need to see a special? Absolutely no. You can go to a family doctor and they can easily organize an AMH assay. Of course, here in IVF Australia, we do these tests, and a lot of big labs also do these tests. I think the important thing is the discussion afterwards about the implications of that. Sometimes some of your doctors may feel more comfortable getting you to see a fertility specialist to talk about the actual result. So, but go to your family doctor first. The majority of them are very happy to do the test and discuss the results with you. Amy Louise asked, can you do anything to improve egg quality even if you have low AMH? Okay, so I'll go back to what I said. I mean, look, this is a good question because everybody asks me that. Okay, everybody asks me that. When I say, well, your AMH level is a bit low, there's concern about egg quality, they'll say, so what can I do, doctor? What can I do to make it better? So like I said before, low AMH does not mean your egg quality is low. I don't know that for sure, okay? And at the same time, I've got nothing to offer you that's proven in scientific research to provide you to improve your egg quality. But I think I should answer this question another way, as to say, what can I do not to make things worse? And that would be, I would think, lifestyle things. No smoking, no drinking. Obesity issues, so weight, looking at weight. And if you look at your weight, then obviously more importantly will be diet and exercises. So in terms of diet and exercises, I'm sure everybody knows the principle: have plenty of vegetables, minimize fat, not have, people, we now talk about high GI and low GI carbohydrates. Try and exchange your high GI food for low GI food and spread out your glycemic load throughout the day. So frequent small meals are usually the best. Exercises, just keep moving. Doesn't have to be strenuous exercises in the gym or, boxing classes or anything like that, but just going out for a walk 30 to 40 minutes, 3 or 4 times a week to get a little bit of sweat out. That in itself is enough exercises. Okay, now let's have a look. And I have some questions here. Okay, what can I do as a young woman in my 20s, running out of eggs fast, but not sure why? So I think that goes similar to what I was talking about before, that I presume there was an AMH test done somehow, so you are more aware of eggs running out. You do need to think about, whether having children is important to you. If that is a situation, then perhaps we need to look at your gynecological history as well to make sure, is there anything else that can potentially make things worse for you? And then if having children is important for you, and I am assuming you don't have a partner, which may be wrong for me to assume, but the consideration is maybe freeze some eggs, which involves going through an IVF cycle and then going through an egg pickup. And then the lab will assess the eggs we get out, are they mature or not mature, and then we'll bank them. Okay, so let's have a look. Okay, Hannah said, I'm 30 and have had one failed egg collection through IVF. Husband has a genetic disorder. Only 4 follicles matured and no eggs. Diagnosed with low AMH and have been told to go and try it naturally for 6 months. Do you agree with this, or can more be done? Let me just read the question again. 30 and have had one failed egg collection through IVF. 4 follicles mature. Husband has a genetic disorder. Okay, that's not a good cycle, I'm afraid. And I think you know that as well. Yeah, I'm not entirely certain why you're being advised to try naturally for 6 months, because you too have obviously made a decision because of your husband's genetic disorder that I will assume that you have decided to go through IVF and then undergo genetic testing of the embryo to minimize the genetic problem and put the right embryo in to help you with your success. And as I said, a low AMH does not necessarily mean bad quality, but our quality does go up and down at times. So sometimes your body sends out a batch of eggs, which are not that good. And the next month, you may come up with a better crop of eggs. That's our natural physiology. So I certainly think it's perfectly okay for you to go back to your doctor, have a look at things, and to make sure there's nothing missed. Go back and look at the sperm factor, egg factor, have a look at your cycle, the stimulation, see if there's anything you can tweak and maybe do better. Because I think the decision is already made. That because of your husband's genetic disorder, that you potentially can do better with IVF. So I think you should keep going and persevere. Okay, what is the process of IVF from first consult to implanted embryo? Maria asked that. Thank you, Maria, for that question. Okay, I will go through this because I've been talking around IVF without, without going through the whole process for you. So let me just say that what we do naturally in a physiological cycle is that at the beginning of the cycle, a crop of eggs starts growing. But our body's physiology, energy really can support one egg. So about a few days into the cycle, your body's already decided which one is going to be the egg that ovulates. All the others grow halfway, stops, they die off. So what we do in IVF is ultimately we're playing a numbers game. And we will take over the control. So your body's mechanism doesn't let you ovulate too early. And then we give you more of the hormone your body will normally produce and support every egg from that crop, hoping they will all mature up. And so we can find that good egg in amongst the lot. So we play a numbers game, and we hope by getting lots of eggs, we find that golden goose, if you like, in there, right? So once you take all these hormone injections, majority of them are for hormones your body will produce yourself, except you give them to yourself in bigger doses. And then we will help you with monitoring, with blood tests and ultrasound. And they give us an intelligent guess of how the eggs are growing, whether your eggs are ready. Then we'll give you another shot to let the eggs undergo the final maturation process. And then we organize the egg pickup process. The egg pickup will be, a day surgery kind of procedure done under sedation, so you won't feel the pain. But you do get a bit of bloating and discomfort for a couple of days afterwards, but nothing terribly serious. And so we'll get all the eggs out, and we get your husband's sperm, your partner's sperm. Generally, IVF is fertilizing outside the body, but it's still fertilizing naturally. So we prepare aliquots of sperm, about 50,000 or so sperm per aliquot, and which will squirt it into the tray containing one egg. The next tray with the egg also squirted in. And then they look at it, next day, how many fertilized. Then they get into in our fancy embryo scope. Then the scientists can observe them through time. Then we cultivate them to day 5. And with our computer system and the scientists, we jointly make a decision which embryo is the best. And by day 5, they're usually at this stage called blastocyst, which means they are starting to differentiate into placenta-forming cells and baby-forming cells. And then we put what we consider the best embryo, the one with the best chance, into the uterus. You may potentially still have a couple of embryo just as good, still have great potentials of getting pregnant. And somehow maybe the computer just thinks the other one was better for whatever reason. And then we still will freeze those other equally good blastocysts so that you could potentially come back and use them in another cycle, or after you had the baby and come back and use the other two. So that's our process. I'm going to move on. And Natasha has a question. I have PCOS. I have one child, which I felt naturally. That's great. That's excellent. Okay. But wish to have another child. Being a single woman, I would be looking at using a donor. What will the process for this be, cost, etc.? Where do I start? Yeah, you look, fertility journey, I tell you, it is overwhelming. For even those with the simplest kind of outcome, people who do one cycle and get pregnant, even for them, it is overwhelming. So the way to start is possibly visiting your doctor and organize a referral to see one of the fertility specialists. Now, here in IVF Australia, we have a very well organized and big donor sperm bank. And so you can certainly use de-identified donors. And so what you would do is have your history and physical examination done by one of us. and possibly a few tests done to look at, hormonal problems and check your tubes and all that. And then you will get in touch with, through us, you get in touch with our donor team, get yourself on the donor wait list. And then what we will do is do the counseling sessions with you with the donor team. And then you come back to us once you're sort of on top of the wait list, if you like, and we reassess all your results, design the cycle. There's a potential that you could use because you've got a successful pregnancy. So that already puts you in a good, prognosis group. So you could potentially do intrauterine insemination with the donor's sperm. And we might just give you a few fertility booster tablets and do that. And you can try a couple of cycles. And if you don't succeed, then we may consider IVF treatment with the donor sperm. So the IVF treatment is going to be the same. But where to start? Either you contact our donor team, and we'll have a 1-800 number, so you can contact us through that, or you can use our 1-800 number and contact any one of our fertility specialists as well. Okay, so good luck to that. Marwa asked, until last year when I was having my ovulation day, I was having pain or uncomfortable feeling around my tubes area, but now I'm not feeling anything. Does that mean anything? Well, Marwa, does not necessarily. Now, some people do feel their ovulation. So they feel uncomfortable around their lower abdomen, which I presume that's where you interpret as it's my tubes area. But not everybody has symptoms with their ovulation. And if you're concerned about your ovulation, the first thing to think about is your period regular. So I think if you're having very regular, 28, 32 day cycles, then almost always you are ovulating. If the concern is still there, you can always go to your family doctor and do a progesterone assay in the luteal phase, and that will also give you some information as to if you're ovulating. Anyway, I'm sure it will all work out very nicely for you. Okay, Marina asked, just wondering which drugs you will prescribe for a 42-year-old. I have success with Gonorrhea and Luveris last March. That's great. That's fantastic. Your son is 8 months old. That's great. I only had a double transfer and miscarried the other. Okay. Was a very low dose I was on with Gonorrhea. Thank you so much. I'm also about to stop breastfeeding. Well, Marina, thank you very much for your question. And I think you've done very well. So you had a baby when you're 41. And that's good because pregnancy chances isn't that high at that age. So that, again, puts you in a better prognostic group. And I can't see why you can't use Gonorrhea and Luveris again if you had success with it. Cycle to cycle is going to be different. So it doesn't mean you're going to behave exactly the same way. And it doesn't necessarily mean just because you got older, somehow you're going to stop responding to Gonorrhea and Luveris, or we suddenly have to change medication. Your doctor will need to reassess your situation and maybe tweak your cycle style or your medication dose slightly. But, I think I do feel quite positive because, look, you managed to have a child when you're 41. I do say don't wait too long, though, because age does catch up with us quickly, especially after 40. And Kat has a question saying, any advice or evidence on effectiveness of back-to-back cycle or to skip a month? That's a very good question, actually, because when I started training, I tell you, when I started training, it was a long time ago. We used to after one cycle, we skip three months and then do a cycle. And then so years down the track, it was like 1 month. And now there is actually evidence it makes no difference doing back-to-back cycles. However, if you do back-to-back cycle, I will assume your previous cycle didn't succeed. Really, it is time, after the failed cycle, really it's time to sort of take stock, you know, reassess. Why didn't I get pregnant? Can we do better? What can we tweak? What can we change? So sometimes you do still skip a cycle because maybe there's some things to think about, some investigation to undertake. So that may be important. That's obviously important. So that may require you skipping a month just to get all the investigation all done. I hope that helps. Bajit, I hope I pronounced your name correctly. As a sperm donor, what are the things, special laws that a donor should keep in mind? E.g., I was told kids have a right to know the identity of the donor when they turn 18. Are there any groups for donor that he can talk to before the donor can make this big decision? Right. So I go back to the end of your question first. We run donor clinics. I think we run it through our York Street city clinic. Now, I may not be exactly right about that, but do ring our 1-800 number because the ladies there can help you with exactly where that clinic is run. So the potential donors can go in there to discuss all these issues about the laws and about what tests that's undertaken and all things related to donating. But in terms of the law, yes, the New South Wales law stipulates that there's a registry for all the donors, so we know who they are. And when the child turns 18, they can have the right to access donor registry and potentially seek out their biological father. And all the donors we have are recruited this way. We also have US donors, and they are also recruited. That's according to the New South Wales legislation. Okay, so I hope that helps you. Okay, so Hannah asked another question. What might someone not respond well to fertility drug? Why might someone not respond well to fertility drugs such as Gorman-F? Well, Hannah, I think there's quite a potential various response to that. So I've alluded to a bit of that before. So from month to month, your body releases small crops of eggs. Some month your body sends out a nice lot. Some month your body sends out a dart kind of lot. And we can only try and get them all stimulated and hope to find a good one in there. So there's quite a possibility that when you responded well before and then you don't respond suddenly to one particular cycle, it's that follicle wave that you've been given for that particular cycle rather than the medication itself per se. So I think that's more than likely the reason. And of course, age is a factor, but I think you previously told me that it hasn't been that long since from having had a successful cycle to a recent cycle. But the thing is, from when we're 40 onwards, the declining egg quality does go down quickly. So it's like, say, when I'm 30, maybe every cycle the eggs that come out are very good quality eggs. Then when I get to 35, then there's some good, some bad. So possibly once you're 40, there are more crops coming out they are potentially sub-quality eggs. So that is a possibility that we, just with age, we're ending up with more poor quality cycles. So I think that's probably the reason. Now, Deb asks, hi Deb, yeah, good evening to you too. I'm 42, low egg reserve and PCOS. First IVF cycle with gonorrhea 450 was cancelled due to high progesterone. Second cycle with menopause 600 went to egg collection, showing 4 to 6 follicles, no eggs in the follicle. Could I have ovulated between my last blood test and egg collection? What causes no eggs in the follicles? Not sure where to go from here. Oh, I'm sorry, Deb. It has been tough, hasn't it? Now, let me just say that most people with PCOS actually have better egg reserve. But we do see people with PCOS with low egg reserve as well. So unfortunately, you must be one in that category. And using gonorrhea 450, they are very high doses, and menopause 600, they are high doses as well. Occasionally, we do see egg development. So remember I said, when we do an IVF cycle, we use ultrasound and blood tests, and it's an intelligent guess. So we look at the follicle growth to say, oh, okay, 16 millimeter, good, possibly a good egg in there, or eggs in maturing. But there are times, like I said, this whole egg wave, if you like, the wave of the good and the bad eggs. If you're in a bad bunch, in the follicle, it could be empty, no eggs. So that when you've got the hormones around the egg, where the egg's supposed to be sitting, still producing the hormones. So we think the hormones are good, the follicle's growing, and yet when we're going and do egg pickup, there's nothing. I do say that's rare, but if you ask any fertility doctors, it's happened to all of us, at least once in their career. And I won't say it will necessarily happen again. But the fact that you need quite big doses to stimulate does reflect declining egg quality. Once again, remember the waves of eggs I'm talking about? So there are still potentials that you get a better quality another time. And there are different types of cycles. Sometimes we tweak and we do different things to help use a different style of cycle to see whether we can change something different. So it's not entirely without hope. There's still a bit of hope. I think you go back to your doctor and consider tweaking the cycle slightly to see whether you could do better. That's my take on what you've said. Michaela asked, is there any research evidence that suggests that taking vitamin supplements can help with egg quality? I'm glad you asked that, because I think I said previously that you will see a lot of claims and remedies, but there's nothing proven. But I did think I need to give you a bit more detail. Basically, what's being claimed, all the claims and so-called remedies out there work on a couple of principles. One, they're looking at improving the energy production of the egg. Two, they're thinking of increasing the supportive steroid production around the egg to give more messages for the egg to grow better. Three, it's about reducing the oxidative damage of the egg using antioxidants, okay? So the kind of vitamins you will hear about, and I think the whole world is on it, CoQ10, right? I think half the world is on CoQ10. Now, CoQ10 boosts, is important in the sort of energy, it's an enzyme important in energy production. is present in all the cells, all the cells. So it has been shown in animal testing and to have some benefit. But what is to say that if I give you some CoQ10, they would necessarily go to your ovary and support your eggs? Now, with all these claims and remedies, the most important thing is sometimes we will go to them because we're on this tremendously difficult journey, and really, is anything that can help, I'm going to give it a go, and which is completely understandable. But the most important thing is whatever you take shouldn't cause any harm. And CoQ10 is one of those that hasn't been shown to cause any harm. So therefore, it doesn't matter if half the world's on us, it's fine. If it helps, that's great, right? And then antioxidant. You would hear about melatonin, which is normally used for people to correct jet lag. But melatonin has antioxidant activity. There's a lot of trials going on about antioxidant, and it really does have some promise. But at this stage, we don't have any good data to give you. And again, we haven't seen any harm from them. Potentially, though, if you take it during the day, it can make you a bit drowsy. So if you take them at night. And so it is aimed as an antioxidant to reduce the oxidative damage in the eggs, and potentially it does help with egg quality. So no harm if you want to take them, by all means. Now, then there's DHEA. You can tell I'm not going to be a fan of DHEA because I left it till last, okay? DHEA is supposed to boost the steroidogenesis for the cells around the egg, and thereby improving the message between the support cells and the egg, and boosting egg growth. There's a problem though. Sometimes people get funny elevations of progesterone and others won't. So you don't get a consistent finding. And progesterone to us is very important because it tells us whether whether you've ovulated, to whether the uterine lining is appropriate for the embryo to go back. So if the medication is giving us wrong progesterone signals, then we don't know where we stand with the cycle, and we may end up putting the embryo back at the wrong time. So I usually would tell my patients to stop the DHEA. So I'm not a fan. I mean, there are others who will use DHEA and monitoring all the levels very closely and all that. But I rather that we don't use DHEA. So that's my take on these things. I hope that helps you. Okay, so now I have Rachel asking, what kind of testing do you recommend getting before starting an IVF treatment? Okay, yeah, that's a very valid question. Yeah, so now to start an IVF treatment, obviously you want to get pregnant. So I think it's important to get antenatal testing done. Make sure you're immune to rubella, German measles. Make sure you're immune to chickenpox, zoster, and consider genetic testing for autosomal recessive conditions, and your blood group, and hepatitis B, C, and HIV screening. These are all standard antenatal testing tests that obstetricians will normally carry out. And then comes the sort of fertility-related issue, the blood tests that you are specifically asking, I would assume. So we check for ovulation. So we do a progesterone test in the luteal phase, the second half of the cycle, and there will be progesterone rise to indicate the person has ovulated. And of course, we take a history to correlate with the blood test. We check their thyroid function. We check their prolactin function, which is the milk-producing hormone. And we sometimes test for testosterone, it's a correlation with post-ovarian syndrome. And we test for baseline FSH and LH level. So those are kind of the general hormonal tests we will do. Some of us will do some very generalized autoimmune testing, but that's certainly not, like necessary as a pre-IVF type of testing. And most of us will do another simple genetic testing for both couples, which is the chromosome testing for both couples. Very few couples will have, very few people will have chromosomal problems, but every now and then you pick up one or two. So the rate is about 2% or so. And they certainly was special kind of IVF type of treatment. So it's good to screen those people. And the test in IVF Australia is free. Bulk billed, sorry, for the genetic testing. Okay, I hope that helps you. And but go to your doctor or your fertility specialist, and I'm sure they'll organize it for you. So Anna, I want to ask, can you explain how a Flair cycle works and potential success rate? Yes, we haven't done a Flair cycle for a very long time. Had one cancelled cycle prior to a Flair cycle, which I just started with Alonva and Cineral. Yes, so yeah, so Alonva is one of the gonal F, basically similar to FSH, and your Flair cycle will start with the beginning and stimulate and then suppress. So Flair cycle is very rarely done now. And I would suspect your doctor is trying to see something different because you had a cancel cycle, trying and see whether different things can improve your outcome. Now, the thing is, us human beings are built, as humans, we're all slightly different because otherwise life is very boring. We're not Boeing 747, which is built exactly the same way, so you do everything exactly the same. So you might respond better to a Flair cycle, even though we haven't done it for, we very rarely do it now. But you could potentially do better with it. And others may, generally, most of us do a particular cycle, but some people may not do as well on that. So when you have a cancel cycle or fail cycle, it is quite likely that your doctor will have a look and reassess and try something different. Now, this may not be evidence-based, but it's just as human variations that sometimes you will do better with a particular style of stimulation than another style of stimulation. Okay. Oh, we're here for nearly an hour now. Oh, gosh. Let me see. I will answer one last question. Okay, someone asked that a 30-year-old with low AMH had failed a collection. Should she still try naturally? Now, again, that goes back to what I said before. Low AMH does not necessarily equate poor egg quality. Even with low AMH, even with poor egg quality, that golden egg we're looking for, it can always come. So your pregnancy chance is never zero. So there's always some chance of getting pregnant. But if you got a low AMH level, and there has been decisions made, of course, to do IVF for a reason, I wouldn't stop just because we had a failed egg collection. It is time to take stock, reassess, try and do something different, and try and do better. And I would think you, in fact, have less time to waste. So I would keep going with that IVF. So that's my answer to you, and I hope that helps. Now, I obviously have enjoyed this a lot more than I thought I would. So I've been here talking for a long time. And I really appreciate all your questions. And I don't have to sit there and talk to myself, which is great. I want to wish you all the very best to your fertility journey. And from all the questions that I've had today, I know that some of you are doing it very tough out there. I want to finish with two very cheesy quotes for you. So I hope you don't mind. But you know, there's a pandemic and you guys are struggling with your fertility problems. And I heard these two quotes recently and I found them so inspiring because, you know, I really want to go back to my old life as well. The first quote came from Nelson Mandela, and he said, "Judge me not by my successes, but by how many times I fell down and got back up again." And the second quote, and everybody knows this one, because life wasn't meant to be easy. But a lot of people don't know. Malcolm Fraser's full quote was, "Life wasn't meant to be easy, but take courage, for it can be delightful." There is still delight in life everywhere we look. So I encourage you, and I want you all to take courage, pick yourselves back up, and we should all move forward and we should all keep going. Do check on our website for additional information. Ring us on our 1-800 number. And I also have my own website. So I look forward to all your inquiries. But for now, it is good night. And thank you once again for tuning in. Bye-bye.